So we are good to start. With all your permission, can we begin?
Yeah, okay. Yeah.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. He is none other than Dr. Pratik Tripathi, sir. With great honor and with great pleasure, I would like to welcome sir at our platform. Sir is MD in Medicine, DM in Nephrology, Head of Nephrology Department at the Multispeciality Fortis Escorts Hospital, Jaipur. With the help of sir, we'll be taking a close look on today's topic, which is nephrolithiasis. Before moving on to today's session, let us have a brief look on what the topic contains. Nephrolithiasis, commonly known as kidney stones, is a common urological disorder characterized by the formation of solid deposits of minerals and salts in the kidney of urinary tract. Nephrolithiasis affects people of all ages and can occur due to various factors such as dehydration, diet, genetics, and underlying medical conditions. We'll be knowing more about the topic and about the inputs with the help of Sir. So now, without any further delay, I would like to welcome Sir at our platform and would like to hand over the session to him for his talk to begin. Sir, over to
you. Good evening, ladies and gentlemen. Today I shall be talking about renal calculus disease, in other words, what's known as kidney stones. Next slide, please. Yeah. So generally, how do these kidney stones present? You'll come across your patients typically presenting with flank pain, which may radiate to the groin or to the scrotum in males, and sometimes the pain, is localized as well, but generally it tends to migrate, or rather radiate, and the pain is unaffected by movement. If you ask your patient when there is pain, how do you get relief, or what kind of posture makes it worse, he or she will not be able to tell you. He or she will tell you that I tried every posture, and apparently without any relief, and apparently without the pain getting any worse. So if you ask him or her whether when you lay down, what happened to the pain, nothing. I mean, it would remain the same. And sometimes there would be other symptoms as well. Depending on where the stone is, if the stone comes down below to the uretrovesical junction, then sometimes there would be irritative symptoms as well. That is the bladder symptoms. Bladder symptoms means the person would feel like voiding, and would in fact rush to the toilet, which is known as urgency, and may void frequently as well with small volumes of urine, and there may be pain during micturition, and the person may even tell you about blood in the urine. Next slide. Next slide. Yeah. So when someone presents with pain in the loin, the typical loin to groin pain, there are other entities which can present like this. And you know so it can, you have to think of other entities as well. It can be because of an incarcerated hernia, it could be an ectopic pregnancy, it could be pelvic inflammatory disease, it could be acute prostatitis, it could be testicular torsion, it could be urethritis, vaginitis, things like that, pain in the groin or in the pelvis. Or if there are dysuric symptoms like dysuria, then you might be dealing with other things like prostatitis, urinary tract infection, vaginitis, etc., etc. Abdominal pain, because abdomen is a big place and there are so many organs, and pain can be produced from any of these organs. So there other entities might exist as well. So whenever someone presents with this kind of pain, one should think of investigating and investigate fast. We'll come to that and we'll talk about the modalities which are preferred here. Next slide. So let us first talk about the stones. Now, renal stones all affect almost 1 in 10 of the population. That is approximately 12% of the population during their lifetime. It seems to be more common in men than in women. And when someone has had stone in the past, the recurrence may occur in 50% over the next 10 years. And those people who have had recurrences, if family history is present in almost more than 50% of these patients. And the apparently stones are more common in certain areas in India like Rajasthan and in Gujarat. Next slide. So, what kind of stones are more common? If we look at children and adults, well, calcium stones are more common. Most are the most common type of stones, both amongst children and amongst adults. And when I say calcium, it could be calcium oxalate, it could be calcium phosphate. It can be both of these together, or it could be a mixed kind of stone which has uric acid or urate and calcium oxalate as well, and calcium phosphate as well. But calcium oxalate apparently are the most common type of stones. Almost 40% of adults have calcium oxalate stones. In children, it seems to be more common than even adults. And there are other stones as well. You have urate stones, uric acid stones. Approximately, 10 to 15% of adults would have stones because of uric acid. In children, it would be just about 5 to 10%. So not that common. The third most common type of stone is the struvite, or the magnesium ammonium phosphate. And this is the so-called infection associated stone. And the incidence is kind of similar in both children and adults. This is the kind of stone which is notorious for presenting as a so-called staghorn calculus. It tends to grow very quickly and become pretty large, so large that it occupies the whole pelvis and the calyces, and it can destroy the kidney. There are, rarer stones as well, like cystine stones. Next slide, please. So there are certain risk factors for stone. Let's talk about these risk factors, like anatomic risk factors. Anywhere where there is urinary obstruction causing urinary stasis, the stone frequency increases. Also, urine composition. People who tend to have hypercalciuria, hypocytriuria, hyperoxaluria, hyperuricosuria, or low pH, continuously acidic pH urine, they tend to have more stones. Those people who do not take adequate fluid, so produce low urinary volumes, they tend to have more stones. There are certain dietary factors as well. So, you know, high acid load, like, egg yolk, cheese, and high sodium intake, high salt intake, low fiber intake, high oxalate intake, um, carbonated drinks like cold drinks like Coca-Cola, Pepsi, etc., etc. Um, People who have hypokalemia also tend to have more stones. Certain chronic diseases are associated with more stones. These include gout. Of course, gout would be famous for getting stones. Even diabetes mellitus, even obese people tend to have more stones. People who have cystinuria, who have inflammatory bowel disease, who have medullary sponge kidneys, who have chronic diarrhea due to whatever reason, they would have more stones. Those people who have recurrent urinary tract infections, specifically being caused by urease producing organisms like Pseudomonas, like Klebsiella and Proteus, they tend to have the so called struvite stones. Next slide. Next slide. Yeah. There are certain medicines which can actually cause stones. Some of them like ampicillin, antibiotics like ampicillin, amoxicillin, even ceftriaxone, fluoroquinolones, they have known to have caused stones. uh, Carbonic anhydrase inhibitors like acetazolamide, topiramate, etc. Diuretics, especially furosemide, especially when used in children, small children, for prolonged periods of time, can produce hypercalciuria and calcium stones. Uh, uh, other certain herbal products can cause stones. As I said, laxatives can injure the gut and cause chronic diarrheas and cause um, increase the absorption of oxalates and can cause oxalate stones. Potassium channel amiodarone, etc., can also cause stones. Um, there are certain other drugs like aluminum magnesium hydroxide. I mean, this is the common antacid that people take. Some people take a lot of vitamin C that can also cause stones. Next slide. There are certain genetic causes of stone as well, and you have famous diseases like the primary hyperoxaluria type 1 and type 2. This particular entity is feared by nephrologists because the recurrences are high even after transplant. And if someone who is young, for example, 30 years of age, with bilateral renal stones and going into renal failure, getting transplant, you have to keep in mind that you might be dealing with this primary hyperoxaluria, and you have to test them beforehand before doing the transplant, because the disease would recur and the graft would be destroyed. In these patients, one would like to do a combined liver and kidney transplant as well. There are other entities like dense disease and cystinuria type 1 and the non-type 1 and xanthinuria. And, there are certain entities like the distal renal tubular acidosis, etc., etc. Next slide. Yeah, let's discuss about individual stone types. So we begin with calcium oxalate. It's the most common type, and it starts as a so-called concretion, which is also known as Randall's plaque. And the important factors which promote calcium oxalate uh, supersaturation and precipitation are dehydration, hypercalciuria, hyperoxaluria, hypernatriuria. People who take a lot of salt would be passing it in the urine as well. And hypocytruria and hyperuricasuria, a lot of uric acid in the urine would also cause stones. Generally, when you look under the microscope, the crystals, the monohydrate crystals, appear like dumbbells, and the dihydrate crystals look like envelopes. Next slide. Here is a brief about primary hyperoxaluria, type 1, type 2, and type 3 as well. Basically, alanine glycosylate aminotransferase deficiency. This causes uh, you know uh, pyruvate to get converted into oxalate rather than anything else, and that causes a lot of problems. I mean, the oxalate forms the stones. Next slide. Yeah. And so those were the primary hyperoxalurias. You have secondary causes where these oxalate would be absorbed and then excreted in the urine in excessive amounts. So people who have chronic pancreatitis, where situations where increased oxalate absorption occurs from the intestines, like in chronic pancreatitis, where small bowel resection, celiac disease, Crohn's disease, even the use of somatostatin analogs. And then you have increased dietary oxalate, people who are taking a lot of, you know, um, there's something called star fruit. I remember taking it as a child, but I remember now, but I after reading that, it could have been dangerous taking a lot of this star fruit. Uh, and there are other things like, other sorts of nuts and other things, rhubarb, etc., etc. Taking a lot of vitamin C can be bad as well. And of course, there's another cause is decreased intestinal bacterial oxalate degradation because of use of antibiotics. And others are, genetic variations in oxalate transport and obesity. Next slide. Here is a picture of how it all begins, how the stones are, how it begins as a Randall's plaque, and there is supersaturation, and then, um, uh, crystallization, and ultimately the stone forms. The nidus may be a different stone altogether, a different mineral altogether. It can be uric acid, it can be anything else, but oxalate can, covers it up and forms the stone. Next slide. Now, coming to uric acid stones, they are pretty common as well, as I said, and most commonly it's known to occur in people who have persistently acidic urine, especially who tend to lack the so-called postprandial alkaline tide. So persons who are taking a lot of meat, eating a lot of meat in breakfast, lunch, dinner, there are people who do that. They would be at high risk of this particular entity. And other things, it's not necessary that one has to have gout to get these uric acid stones, because just about 20% of these uric acid stone formers have got gout. And it can be seen in other entities as well, like in diabetes mellitus and Lesch-Nyhan syndrome. It can occur acutely, causing uric acid nephropathy, acute uric acid nephropathy, which is associated with acute kidney injury in situations where there is tumor lysis syndrome, for example, in leukemia or lymphoma after treatment, after chemotherapy. So uric acid is basically a byproduct of purine metabolism. And when you look at under the microscope, when you look at the crystal, it looks like a rounded parallelogram. You can see the picture here. Next slide. Now coming to struvite stones, they are caused by urease producing organisms. These organisms are Klebsiella, Proteus mirabilis, Pseudomonas as well. So basically, urea is broken down into ammonia, and ammonia makes the urine alkaline, and then you have phosphate in the urine, which precipitates in the alkaline pH, and then it becomes insoluble. It combines with the ammonium which is there, and with the calcium as well, and then magnesium, everything, all those minerals are present in the urine per se. So it becomes very easy for the stone to start to form, and it can form there can be rapid growth. It can become pretty large, and it may not even produce symptoms. These people, whenever they are discovered, most of them, if you ask them that you have such massive stones in your kidneys, didn't you feel a thing? How come you have come so late? And they tell you that we never felt a thing. We didn't know that there were stones growing up inside our kidneys because we never had pain. you know so that it's pretty common for these patients to actually not complain of anything. And when you look at the urine, you typically find crystals which look like coffin lids. And whenever you're looking at the urine, you're doing a microscopy and you find coffin lids. Coffin lids are always abnormal. It's true. Why these crystals never exist in so-called normal urine. And normal urine can have oxalate crystals, it can have, urate crystals, but which would never have ammonium crystals, which look like coffin lids. Next slide. Then there is a rare entity known as cystine stones, and basically homozygous. One has to be with homozygous recessive gene for cystine transport. This causes excessive urinary cystine levels, and cystine tends to crystallize and form stones. And if the urine happens to be acidic, more stones are formed. This is a rare entity. Normal urinary excretion is less than 100 milligrams of cystine per day. And these patients may have more than 600 milligrams of cystine in the urine per day. Next slide. Next slide. Now, coming to calcium phosphate stones, calcium phosphate stones tend to form the nidus for most calcium stones. For most calcium stones. Pure calcium phosphates, pure calcium phosphate stones tend to occur in situations like primary hyperparathyroidism, in renal tubular acidosis, and in medullary sponge kidney. And you need to have an alkaline, generally you need to have an alkaline pH to have calcium phosphate stones. Next slide. So how does one go about diagnosing kidney stone? Next slide. So when someone comes to you with flank pain, previously what we used to do was do an X-ray of the, X-ray KUB, so-called X-ray KUB. If you happen to be sitting in a district hospital, maybe that's what you may order. But the gold standard is actually a spiral CT, a KUB, without the IV contrast. You could use an ultrasound to make the diagnosis, but ultrasound generally would not pick up a ureteric stone. So indirectly, you may be able to figure out that there may be ureteric stone if you find hydroureteronephrosis on ultrasound. However, because CT scan is something that you cannot do or would not like to do in pregnant women, so you're left with no choice but to use an ultrasound in these particular patients. X-ray, as I said before, could diagnose most of these stones, but some stones would be missed, especially uric acid stones. So if you don't have a CT scan, then you could get an IVP done. You have to give contrast and get X-rays done so that you can see that there is indeed an obstruction somewhere. And though the particular stone may be radiolucent and wouldn't be picked up on an X-ray, but if you do a CT scan, all stones are picked up. All stones. Next slide. Yeah. Well, um, stones are formed somewhere in the calyces near the papilla, and then they move on, they can travel, and they tend to get obstructed at some place, certain places like the pelvic ureteric junction. That is one of the places where there is a constriction, natural constriction. There are three natural constrictions. The third place is where, the where it enters into the bladder, so it can get get stuck over there. So when it gets stuck in the ureter, then the following things happen. There is an initial phase lasting approximately 2 hours where the pelvic pressures rise. The blood flow also tends to increase in the kidney, though the urine is not able to pass on, and the pelvic pressure increases. Uh, However, the GFR would starts going down. At 6 to 24 hours, the pressure is still high, but the blood flow now starts decreasing. So there is vasoconstriction in that kidney on the side where there is obstruction. And after 24 hours, the pelvic pressures are still down. They keep on going down, and the renal blood flow also keeps on going down. So when there is an obstruction of the ureter, the renal function, that kidney, the renal blood flow diminishes, and at certain point, it can actually become damaged by ischemia, more by ischemia because of decline in its renal blood flow, and rather than the back pressure, so-called back pressure from the obstruction. And if the stone remains stuck for more than 2 weeks, you are looking at permanent damage in the kidney. Next slide. So how are these stones managed? Next slide. So what are the situations where there would be an urgent intervention would be required? So if there is an obstruction and infection, then this is a urological emergency. The patient has to land up in the emergency, get evaluated by the urologist, and the intervention has to be done very swiftly, because an obstructed urinary tract with infection, with pent up pus, uh, is like a bomb going off. It would go off, and this person would have septicemia and septic shock and would die if intervention is not done quickly. Number two, if someone has a solitary kidney and it gets obstructed, one would never want this solitary kidney to suffer damage because of the obstruction, and the obstruction has to be taken care of as quickly as possible. Number three, if there is a lot of pain, then the person should seek, relief, and the doctor should obviously offer relief as quickly as possible. And same applies to intractable nausea, vomiting, because there is a real danger of this person getting dehydrated and getting acute kidney injury because of dehydration, in addition to the renal ischemia, which is occurring because of the obstruction. Next slide. So in the acute setting, you do an imaging study, you find out um, where the obstruction is, and you send the urine for culture and sensitivity, because if the urine is infected, then you'd like to be you would like to ensure that you have given the correct antibiotics. You get the basic investigations done, like the CBC, the RFT, and the electrolytes, and you go for percutaneous nephrotomy. So this is what the urologist does, or you can go for a so-called DJ stenting, which you do after doing a cystoscopy. You can do the DJ stenting after nephrostomy as well. Next slide. This is a description of the kind of treatment that you'd like to give to someone who is having so-called renal colic or ureteric colic. So analgesia and antiemetic are the first thing that you give. If you can give painkiller, that is an NSAID, because the person is otherwise not at risk of renal failure, chronic kidney disease, because he's not elderly, doesn't have heart failure, is not diabetic, doesn't already have CKD, then you can actually go ahead and give that person NSAID, because NSAID tends to work very well. You can use ketorolac, which works pretty nicely, and you could use diclofenac. Some people have used intravenous lignocaine. This is for experts, not for everyone. Some people have used it for intractable renal colic with salutary effects and with no adverse events. But you have to be absolutely sure that the person doesn't have a cardiac condition, because lignocaine happens to have, it's also used as an antiarrhythmic. It's also a so-called local anesthetic, but you could use it as an intravenous for intravenous analgesia as well. You could use opioids like morphine rarely, because mostly NSAIDs tend to work pretty well. But in some patients who have underlying issues, like, as I said, underlying CKD already, you wouldn't like to use diclofenac or stuff like that. Then you would like to use something like morphine. Morphine is generally not easily available in our scenario. So you could use other drugs which are available in your scenario. Um, uh, Hydration has to be maintained. You could give a high amount of fluid to so-called try to flush it out. We'll see what kind of stones do get flushed out and what kind of stones never get flushed out. You have to look at the size of the stone and the location as well. You could use an alpha blocker like tamsulosin um, for taking care of the ensuring that the ureter relaxes a bit and the stone can move down uh, further. And then, of course, then you have various ways of taking care of the stone, invasive and non-invasive ways. Invasive ways like ureteroscopy and nephrostomy and everything. And then you have the so-called lithotripsy, which is non-invasive. uh, Next slide. Yeah. So this is it. What size of stone do you think will pass spontaneously and can be treated conservatively? So let's look at it. Yeah. So the stone size, if it is two or less, like likelihood of intervention are quite less. 2 millimeters or less. Less than 3% actually require an intervention. Most of them tend to pass within 8 days. And look at the other end, which is more than 6 mm. More than 6 mm means 99% of the time it's not going to pass on its own and it would require an intervention. So 4 to 6, it is still 50-50. 4 to 6, 50-50. And if it does pass, it will generally pass within 22 days. So if it has not passed within 22 days, then you'd rather think that it requires intervention. Next slide. So there are surgical and non-surgical options for renal calculus disease. Next slide. Yeah. Um, well, certain stones, uric acid stones, you could try, using, dissolving it by taking potassium citrate, keeping the urine alkaline. So uric acid stones, 5 to 10%, which are 5 to 10% of all calculi, can get dissolved if you're taking, potassium citrate. So not all stones would get dissolved. Then you have lithotripsy, which basically uses extracorporeal shock wave. Uh, and then you have other things like ureteroscopy and laser lithotripsy. So there you basically directly visualize and fragment the stone and fragment it using a laser. And this you can do via a cystoscopy or via nephrostomy. And percutaneous nephrostomy is generally done for staghorn calculi because they're pretty large and but they're soft. The stones are soft as well, so you can break them up. Next slide. Yeah, this slide basically talks about the kind of stones that can be, what are the complications like with lithotripsy, and the kind of stones that you can actually utilize this particular procedure on. So, um, and the places where it's contraindicated. For example, lithotripsy would be contraindicated if the person has coagulopathy, has an acute, has an ongoing infection, happens to be pregnant, you wouldn't like to do that. And if you're not able to see the stone, so you would not be able to focus on the stone. So you would not be able to use this procedure on the stone. And there are certain stones which will not break. For example, cystine stones, they're very strong stones. So they will not break using lithotripsy. Next slide. Uh, all these procedures can also be done in pediatric patients as well. So, um, however, there are certain complications which can be, which can happen, like perirenal hematoma. Rarely, few patients have got anti-GBM disease after lithotripsy. That's a rare cause of anti-GBM disease. Next slide. So after the procedure, how many of these patients actually remain stone free? Apparently, the percutaneous PCNL, the percutaneous uh, nephrolithotomy, is very successful. And even when you do it using cystoscopy and ureteroscopy, it's very successful. And open surgery nowadays is quite rare in today's patients, but open surgeries apparently are the most successful because you are able to see everything in direct vision, and you have control over the whole situation, and you can take your sweet time to remove these stones. Um, Lithotripsy is not successful. It's only successful apparently in 50% of cases. So after 50, the stone-free rates would only be possible in 50% cases of lithotripsy. Next slide. Yeah, so if someone comes to you with acute renal colic, what are you supposed to do? You're supposed to do a CT scan first, and CT scan shows that there is a stone. So there is a so-called urgent pathway. What is the urgent pathway? Urgent pathway is where there is an infection, associated infection, or there is severe pain, or there's a lot of vomiting, then or the single kidney has been affected, has been obstructed, and so you have to intervene. So you call in the urologist, and the urologist does his job. I mean, it does, takes care of it. So if none of these things are there, it's not that urgent, then you can even think of, you assess the likelihood of the stone passing on its own. We have already seen the size of the stone, the size of the stone which can pass on its own. So if it's more than 6 mm, it's not going to pass. So you can forget about so-called conservative measures in those particular cases. So you observe where it will pass. You give the usual treatment, that is tamsulosin. If you think it's a uric acid stone because there was a uric acid stone in the past, or the person has an entity which causes uric acid stones, for example, gout, then you can use potassium citrate and try to get it out. And of course, you have to hydrate that person, and you observe for that period of time. And if it doesn't pass on its own, then you can intervene. The urologist would intervene. And in case it's not a stone, then it would, whatever the cause is, that has to be taken care of. If if there is pain and you do a CT scan and you don't find a stone, but you do find hydronephrosis, there's possible obstruction, then you have to find out why it is. And it could be vesicoureteric reflux, it could be a mass, it could be a soft tissue like a papilla, breaking off and getting stuck in the ureter. So that has to be evaluated by the urologist, and the urologist should always be involved. Next slide. So what measures are you supposed to take so that the stones do not form again? Next slide. Yeah. So there are certain class of patients, these stone patients. You don't evaluate every stone maker, but there are certain patients that you have to give you have to give a lot of attention. And who are these? And they have to be evaluated in total so that you figure out what is going wrong, so that you can find the underlying cause and take care of it. So who are these patients? Those who have recurrent stones and bilateral stones, those who have a solitary or a transplanted kidney and they are going to have stones, or they have a GI bypass surgery with significant medical comorbidity. So if they get a stone, they are going to get into a lot of trouble. You don't want that to happen. So you have to evaluate these patients for possibility of having a metabolic problem which would cause more stones to form. And all children with stones should be evaluated. What kind of workup should you be doing? You should do a 24-hour urine for volume, for pH, for calcium, for oxalate, for sodium, for uric acid, for citrate, for phosphate, for magnesium, sulfate, and for creatinine. And you could do it for cysteine as well, in case you suspect that cysteine stone are being formed. And you do a serum blood test as well. You do the serum calcium, phosphorus, uric acid, bicarbonate, to look at whether the person has renal tubular acidosis. That possibility exists. And of course, the renal function tests. And you could do an intact PTH as well, especially if you find that the person has hypercalcemia, because you might be dealing with primary hyperparathyroidism. Or you could do a vitamin D level as well if the calcium levels are high. And of course, every time ensure your patient, if when that stone is retrieved, whether it's passed spontaneously or retrieved at a surgery, try to get an analysis done so that you know what is the composition. And sometimes the composition would tell you what the underlying cause is. Next slide. So what are the usual factors which are generally identified um, as the cause of recurrent stones, or stone formation? As I said, people who are dehydrated most of the time because they're not drinking too much, or they stay in a place where they tend to get dehydrated and don't have access to water. And that's why we see a lot of stones in places like Rajasthan and Gujarat. Patients who have hypercalciuria, who have hyperoxaluria, who have hypocitraturia, citrate levels in their urine are low, because citrate helps to keep the minerals in the urine in solution. So if the citrate is low, these minerals tend to crystallize and form stones. And then hyperuricosuria. And as I said, hypercystinuria is quite rare. So anyway, so low urine volume, always ensure people who are not drinking enough, you have to tell them they have to produce more than 3 liters of urine every day. And to produce 3 liters of urine, an adult, if he or she produces 3 liters of urine, he or she should be drinking at least 4 liters of fluid, water every day. Hypercalciuria, reasons why there could be a lot of calcium in the urine, more than the so-called normal, would include increased dietary absorption of calcium, poor reabsorption of calcium by the kidneys. If the kidneys are not reabsorbing the calcium, which gets filtered, or if calcium, more than the usual calcium, is getting released from the bones on resorption, as in primary hyperparathyroidism. So idiopathic hypercalciuria, this happens to be the most commonly identified genetic cause of kidney stone. They are not told to restrict calcium. They are told to take the normal amount of calcium every day, but they are told to do a lot of other things. Limit the salt intake, because the more salt they take, the more calcium will be excreted in the urine, because when the salt gets out in the urine, it also takes calcium along. And they have to drink a lot of water. That means fluid intake, which touches 4 liters every day. And people who have primary hyperparathyroidism, we know what needs to be done. We have to look, we have to find out where the tumor is, and we have to remove it. So it requires surgery. And idiopathic hypercalciuria, one could use thiazides, because thiazides are known to reduce calcium excretion in the urine. So hydrochlorothiazide, what kind of doses are we looking at? Generally, I mean, it's not the small dosages that are used in hypertension, for example, 6.1 to 5 or 12.5. No, not those doses. It could be 25, it could be 50 milligrams of hydrochlorothiazide. You have to be sure that you have to also ensure that they don't get um, hypokalemic or hyponatremic, because they are taking high doses of thiazides, or even hyperuricemia. Their uric acid levels can go up. They can have dyslipidemias as well. So you have to keep those things in mind. Next slide. Next slide. Yeah. Hyperoxaluria, increased dietary intake. People who take a lot of spinach, that is palak. People who are into chocolates and nuts and teas and stuff like that, they can have hyperoxaluria. Even high vitamin C levels. We most of us took a lot of vitamin C during the COVID period, so it could, I don't know. People have not worked on this, but it could have caused a spike in stones. I don't know. Yeah. So enteric, if the intestines are diseased for some reason, for example, Crohn's disease or intestinal bypass surgery, the oxalates are absorbed more, and if they're absorbed more, they're also absorbed more with fat malabsorption, because fat binds with calcium, and calcium was supposed to bind with oxalate, but now calcium cannot bind with oxalate. It has to it was bound to fat. So oxalate is free and oxalate gets absorbed, and the calcium is taken out in the stool. So yeah, hyperoxaluria, if more oxalate is absorbed, more of it will be excreted in the urine and more stones will form. So how do we prevent this sort of thing from happening? We have to reduce the dietary intake of oxalates. We already know where it is. It's in all these spinach and chocolate and nuts and teas and stuff like that. Of course, we would like not to take a lot of vitamin C. We would like to take vitamin B6, because it can modify the hepatic oxalate metabolism. It can cause more, metabolism of the oxalate. And in fact, if you take calcium, especially with meals, less oxalate is absorbed. So it was noticed that people who do not drink enough milk, they tend to have more stones. So that's looked like a paradox, because one would have thought that people who drink a lot of milk, because milk contains calcium apparently, they should have more stones, but it didn't work out that way. The reason it didn't work out was milk, the calcium in the milk would bind to oxalate, and the oxalate and the calcium would pass out in the stools, and both of them would not be absorbed, and so the person would not have stones. So that's how it works. Hypocytriuria. So this is a risk factor for both calcium and uric acid stones, and it tends to occur in situations where there is chronic acidosis, like in renal tubular acidosis, in hypokalemic, in chronic hypokalemias, because chronic hypokalemia can cause intracellular acidosis, and chronic diarrheal states as well, and where you take the drugs like acetazolamide. So um, you need to have at least 600, 500 to 600 milligram of citrate in the urine every day. And your pH should be more than 6.5. It shouldn't be acidic all the time. So potassium citrate is the preferred way of doing it. So potassium citrate is used for this particular purpose. Next slide. So these are the various things that I talked about: high fluid intake, low oxalate diet, low fat diet as well, especially those who are having intestinal malabsorption. They would have more oxalate stones if they are taking a lot of fat, because the fat would be binding with calcium. Normal calcium diet, at least don't you have to avoid low calcium diets. Calcium supplements can be taken, especially in situations where you have oxalate stones. This has to be done with meals, because this calcium is going to bind with the oxalate and prevent it from getting absorbed. One could take cholestyramine as well, because it binds with intestinal bile acids and reduces diarrhea and binds the oxalate. So oxalate, people who are having a lot of oxalate stones or fat malabsorption, they could try this. And then you have certain organisms like Oxalobacter formigenes. It's available in capsules. So it becomes part of the microbiome in the intestine, and it tends to break down the oxalate in the diet. Um, yeah, these are the usual things that we use. Next slide. Hyperuricosuriya. So dietary recommendations means you have to cut down on purines, and purines are present in things which are protein rich, and especially animal protein rich. So these people are told to avoid meats, eh, and they have to take low salt, and they have to avoid alcohol as well. And um, they need to have uh, they have to, if their uric acid levels are high, then they have to have allopurinol as well. They can have allopurinol as well. So someone who has gout, because there are certain drugs like probenecid which tend to cause hyperuricosuriya. People who have gout, this particular drug may be given to cause the uric acid to go get excreted in the urine and bring down the uric acid level in the blood, but it can cause stones in these patients, so it should be avoided in these particular patients. Cystinuria, very rare cause. You have to drink a lot of fluid. You have to take citrates as well. And there's something known as thiopronin, which forms soluble complexes with cysteine and reduces cystinuria. Next slide. Yeah, so these are the various drugs which are used: allopurinol, hydrochlorothiazide, I've talked about it, potassium citrate, pyridoxine. Dosages from 25 milligram to 200 milligrams may be used in primary hyperoxaluria. Um, Captopril has been used in cystinuria. D-penicillamine has been used in cystinuria. This is a rare entity, so we'll not focus on it. Next slide. So urinary stones present generally, they present with renal calculi and hematuria, and a non-contrast CT scan of the KUB is the best test. And you should know when an urgent intervention is required, and you should also know where there is a possibility that the stone may pass on its own. And you should also know which particular patients you have to work on. Basically do the metabolic workup, because you know that they are going to make more stones in the future and their kidneys would be at risk. So this is the gist of the whole presentation. Thank you very much.
Thank you so much, sir, for your comprehensive overview and for the wonderful insights shared by you upon the topic. I think that this is definitely going to help all the viewers who have joined our platform for better exchange of knowledge that has been shared by you. So thank you so much for that, sir. And at the outset, we have received few questions, and I would like to put it across to you.
Yeah. Yes.
Yes, sir, just a minute. The questions are getting downloaded. The first question is, what is the role of what causes struvite stones in nephrolithiasis?
As I mentioned, these struvite stones are so-called infection stones, and they are associated with urease producing organisms like Klebsiella, like Proteus mirabilis. And urease is an enzyme that these bacteria produce. And urease basically breaks down the urea in the urine and it produces ammonia. Ammonia dissolves in the water and makes it alkaline. And then you have this phosphate in the urine. So phosphate precipitates in presence of alkaline pH, and then it crystallizes and it combines with the ammonium. And there are other minerals as well, like magnesium in the urine and calcium in the urine. So all of them form a complex together and they form stones. And in fact, as I mentioned, this particular stone tends to develop quite rapidly. It's a soft kind of stone and it becomes pretty large as well. It may occupy the whole pelvis and the pelvic calyceal system. As a matter of fact, the whole collecting system in the kidney may be filled up with this stone. This basically, it's an amorphous kind of stone, like chalk, almost like chalk. In fact, softer than chalk. You can easily break it, and it can then, since it blocks the whole kidney, it can destroy the kidney over time, and the person would feel no pain because the surface is absolutely smooth, and it in conformation with the contours of the calyces. So no pain, nothing. The person doesn't feel anything, and then the person starts developing renal failure because the kidney has been shut down for so much time. Urine is not making much urine. So the kidney, at some point, the person would come and say, "There's something wrong with me. Come and just check it out." And you find, and you're shocked to see a large stone in the kidney. Yeah. Next question. I hope that answered the question. Yeah.
Hope so, sir. Thank you so much, sir, for answering that question. We'll move to the next question that we have received. And the question is, how is abdominal aortic aneurysm differentiated from nephrolithiasis?
As I said, you have to do a bit of clinical examination. See, abdominal aortic aneurysm would cause pain which projects to the back, because it's lying just opposite in front of the vertebral column. So the bodies of the vertebra, and when it starts growing, it erodes into the vertebral bodies and it can cause pain there. And you have to examine clinically, frankly speaking. So I mean, these persons, for example, who would have an aortic aneurysm, people who have atherosclerotic disease, so they need to be hypertensive, they need to be kind of old, most of them are old, and they need to be smoking a lot. And when you examine, you find a pulsatile mass in the abdomen. And when there could be pseudoaneurysm as well. In fact, some of these branches of aorta may be shut out, so there may be asymmetry in the pulses of the lower limb, in the both femoral. So you can easily figure out. As far as the aortic, the ureteric pain is concerned, as I said, it's loin to groin. It's loin to groin. It's not going anywhere. It's just going from up to down. It's not going to the back. And when you examine clinically, you will not find anything. No pulsatile mass, nothing. Ah, you may, when you examine the back and you do check the renal angle may be tender on that particular side where the ureter has been obstructed, and that's why you have this CT scan. You do a CT scan and everything is clear as daylight. Everything is clear. If it is an aortic aneurysm, it would be very much there. You would never miss an aortic aneurysm on a CT scan anyway. But anyway, even clinically, I mean, ureteric stones generally occur in the younger age group, as I said, and they would not have all those risk factors of aortic aneurysm. I hope that answered this question.
Yeah. Thank you. Thank you so much, sir, for answering this question. We'll move to the next question. You have already covered this particular thing in your talk, but we have received a question related to that. So I'll just put it across to you. The question is, what is the role of surgery in the treatment of nephrolithiasis?
Yeah, see, so surgery means invasive. But even in so-called invasive surgery, you have two types now. You have endoscopic surgery now. Urology has become minimally invasive now. So urology as a branch, as a specialty, has become minimally invasive. No, you don't find urologists cutting people open to do something, unless of course they are doing a transplant. That's a different thing. So they go around with big tubes, endoscopes. So they have a cystoscope, and they put it in the bladder, and they go up the ureteric orifice into the ureter, and they look at the stone, and they break it up using lasers nowadays, and they catch the fragments, and they remove the fragments, they flush it out. So this is the so-called retrograde way. And then you have the percutaneous nephrostomy, where they make a direct puncture into the kidney because there is a large stone sitting there, or maybe in the proximal ureter, and the pelvic ureteric system is all dilated, and it's very easy to puncture the kidney. So use an ultrasound, or under fluoroscopic control, you puncture one kidney, you dilate the pathway, you put your scope inside, you look inside, you find your stone, you break it up, you bring out the fragments, and you put in a DJ stand. So it becomes very easy. So this is how you go about it. The two ways of going about it. And the so-called non-invasive, which is absolutely gone out of fashion actually nowadays, especially in the Indian context, is lithotripsy. Lithotripsy. We used to have lithotripsy in our medical college, but it used to lie, idle all the time. Nobody was interested in using it. They would rather take the patient to the OT and do the surgeries and get the stone out very quickly, and the patient would be gratified, rather than going through sessions over months for a stone to be broken up. But anyway, yeah. So yeah, so surgery has a big role here. But as I said, there are certain stones which can pass out on their own. So a stone which is more than 6 mm is not going to pass out. So if you come across such a stone, and CT scan will actually give you the size of the stone. So the moment you do a CT scan, you know exactly what to do now, because if the stone is more than 6 mm, you have to do surgery. There's nothing you can do about it. And especially if it's causing an obstruction in the ureter. So if it is between 4 and 6, then there's a 50% chance that it may come out. And I said there's a mean time of 22 days. You could give it a trial of a month or so with Urimax, tamsulosin, and tell that person to drink a lot of water, and keep the urine alkaline and things like that, and hope that the stone comes out. Sometimes it does, sometimes it doesn't. As I said, 50-50. And if it doesn't, then after a month you can think of doing surgery. Yes.
Thank you so much. Yeah. You have answered the question, sir. So thank you so much for that. We have received another question, and the last question for today's session. And the question is, what is the stone score and how is it used in the diagnosis of nephrolithiasis?
What is the stones? I didn't get that question.
What is the stone score and how it is used in the diagnosis of nephrolithiasis?
Stone score, CORE.
SCORE.
Oh, stone score.
Yes, sir. Score. SCORE.
Okay. Frankly, I don't really know what is this meant by the stone score per se. Frankly, I would be entitled, and I would really appreciate it if I'm told about this. Maybe the person has something in mind, like when you do a CT scan and you're looking at the density of the stone, and maybe the density of the stone tells you what kind of stone it may be. Frankly, I don't know what is meant by a so-called stone score. Maybe a urologist would be better equipped to answer this question.
Thank you so much, sir. Thank you for answering it. We will check by the question later on. So thank you so much, sir, for taking out your valuable time and for being here at our platform.